Hello, I'm hematologist-oncologist Dr. Tony Talebi. Now we're going to discuss the treatment of chronic myelogenous leukemia, CML. We're back with Dr. Javier Pinilla, Assistant Professor of Medicine at the Lean Moffitt Cancer Center. Thank you for being here.
Thank you, Tony.
All right. Okay, so let's assume that a patient, for whatever reason, has been diagnosed with CML. What happens next for that patient?
Well, first of all, as we were discussing previously, that I think a bone marrow should be indicated to really make sure that we are dealing what we are dealing. When the diagnosis is finally confirmed, many things can happen, but of course we have discussion with the patient about what is the first step to follow, and these include the start on a tyrosine kinase inhibitor, a drug who can really control the disease. Being said that, sometimes we use in this interval of time that occurs between the bone marrow and the confirmation of diagnosis, we may use hydroxyurea as a way to control counts, because in many cases counts can be over 100 or even over 200,000. Means that outside this period of what we discuss with the patient is about tyrosine kinase inhibitor. We have right now available 3 tyrosine kinase inhibitor. The one that the more classical and the one that's been approved since 2001 is imatinib. And we also have a second generation tyrosine kinase inhibitor in the form of dasatinib and nilotinib. Both of them are more potent than imatinib, and one of them, in this case, dasatinib, is able, as well as SRC inhibitor, is what we call more like a pan tyrosine kinase inhibitor, while nilotinib was designed specifically to really improve the binding capacity to BCR-ABL of imatinib. Right now, these 3 drugs are approved by the FDA for the frontline use for patients with CML. And the question that really many patients ask me, say, doctor, which one I should really start? And of course, this is a very, very delicate situation where the patient is under a lot of stress. And I think the best thing I try to do is I put all the facts in the table, and according with the preference of the patient, I really try to find the drug who better fits the life of the patient is across the table. In being said that, certain comorbid condition will really give us a clue why use one drug versus another. The classical example, patient imatinib classically produces severe fluid retention and GI problems, and also can produce rashes. In these cases, in certain situations, won't be indicated. The same is applicable for nilotinib and dasatinib. The classical contraindication that they are not formal, but of course one had to be to take it into consideration are, for example, liver problems or pancreatic problems, when in these cases nilotinib won't be a good choice because the classical side effects that can produce, versus in the case of dasatinib, pulmonary problems like pulmonary obstructive disease, or even like a severe cardiac problems, where in general imatinib or dasatinib won't be my first choice. Based on that, and also based on the administration, imatinib and dasatinib are administered once a day, and nilotinib is administered twice a day, and also require fasting. Means that all these things are put into consideration and put in the table in order to really make the final decision. And I really always like to have my patient participating in this decision, because the patient hopefully will have to take this drug for the rest of their lives in order to control his condition.
So is there any way you risk stratify the patient and recommend one of the 3 pills to the patient?
Thank you for asking the question. We've been discussing previously that because there is a stratification, we can have low, intermediate, and high. And based on recent trials that been compared the second generation TKI, nilotinib and dasatinib, in back-to-back with imatinib, we find out that most of the patient, if not almost all of the patients who progressed in the imatinib arm of these 2 trials called the NSND trial and Decision trial, the patient who progressed on the imatinib were patients who belong to the intermediate and high risk SOCAL scores. for which we believe in the CML community that those specific patients are the ones who benefit the most to second generation TKI. And in my practice, although I really discuss the three drugs with the patient, if a patient has intermediate or high SOCAL score, I really encourage, if not really, I convince the patient that should be treated with a second generation TKI. In case of a low risk, the possibilities are open, means I think the three of them has the opportunity to have a very excellent outcome. And in the future, of course, the fact that imatinib in the next 3 years is going to be generic is going to have, in somehow, an impact in the way that insurance or doctors are going to try to really choose the best medication. Although definitely we know that the second generation TKIs produce a deeper, faster cytogenetic and molecular response of these patients.
I see. How do you assess to see how the patient is responding to the treatment? Would you please go through the milestones again? They're so important.
Sure. And I think it's never really, we need to really reinforce this milestone idea because it's an easy way to remember. Is the 3, 6, 12, and 18 months. And pretty much the 3 months complete hematological response, the 6 months decent, really robust ongoing cytogenetic response, followed by a complete cytogenetic response by 12 months. Once again, major molecular response is something desirable. We like to incorporate in our practice. We like to have this in younger patients more and more because we don't know what's going to happen in many years to come. But definitely, in general, we still, in our CML forums, we still have some debate about the meaning of these molecular responses.
So how do you handle the side effects? Which point do you lower the dose, stop the medicines? How's that algorithm for you?
That's a great question. I think the more important thing is to see how the patient starts to tolerate the drug. Once that you encounter side effects, I think there is ways to support these side effects. The classical ones that we have been dealing for many years on the imatinib is the fluid retention that can be easily managed with low dose diuretics, or the GI symptoms that can be really improved on some kind of antiemetics of other kind of medication, including antidiarrheal medication. Being said that, this a phase for which we try to really improve the quality of life, but I think we need to remember that these drugs are going to be taken for life. Mm-hmm. And because this reason, we need to pay attention how these side effects can impact the quality of life of our patient. Why is that? Because we know these days that the patient has side effects, and even more what we call low-grade side effects can have a profound impact of the adherence of the patient to the medication, and for this reason we can really have a lack of control of the disease in the years to come. And for this reason we need to always be in the lookout. And of course, if these side effects in some way, with or without support medication, represent really a problem for the patient, I think discussion about changing to other TKI is indicated, and the goal will be to really improve the quality of life of these patients.
How do you motivate your patients to take a pill every single day for the rest of their life?
That's an excellent question that we are really putting our forums of discussion very, very often. Adherence is a very, very important problem, or a very important issue in the CML, in the new CML world, because we understand many of our patients are going to be on TKI for the rest of their lives. And we are talking about being on a drug for 10, 20, 30, even 40 years. Mm-hmm. We now, for historically, by research in diabetes or antihypertension medication, that adherence is a problem, means that we need to be continuously engaging the patient on the fact that they need to be taking the medication in order to assure that the disease will be controlled. It's very easy for patients sometimes that they feel great, they have a great tolerance to the medication, start to have this feeling that they think that they are cured. And the word cure cannot be used these days. There's a very, very few exceptions and that they are going to be studied in the future. But right now, we know that these drugs don't cure this condition, for which if most of the patients stop the medication, the disease will come back.
How do you deal with depression in patients that have been diagnosed with CML?
That's a great point. I have a personal experience in many of my patients who, in spite of being very well treated, very well controlled, they're still stigmatized by the fact they have a chronic myeloid leukemia, sometimes because they have side effects, sometimes because the psychological burden that represent that. And from this point of view, I think psychological counseling is very important. CML support groups are extremely useful as patients understand that they are not alone in the world, that many other people suffer these psychological consequences to have really this kind of the diseases. And of course, psychiatric advice or even therapy in certain situations is indicated because some people really cannot really manage themselves without these interventions.
Can a patient have sexual relations while taking these medicines?
That's an excellent question that we are dealing because many of these patients are in the reproductive age. And we will have to differentiate between females and males, right? We now understand that these drugs as mechanism of action is blocking the enzymatic activity of not only BCR-ABL, rather other enzymes, other tyrosine kinases. They can affect to the fetal development, for which there is a formal contraindication to really, not to have a sexual relation, but of course to have really protection while having this sexual relation. And the reason is because there have been studies, and although they are really, really few, they are being shown that there is a potential teratogenicity while a woman who had pregnancy take this medication. Right now is a formal contraindication to get pregnant, or at least to really have all the methods to avoid this problem. Even though we're dealing every year with 2 or 3 cases of females on these drugs get pregnant, and it's a problem because we need to interrupt the medication. In many situations, the disease will come back during the pregnancy, and in this case, I think the better option that we are using these days is interferon alpha. That was an old therapy, not very effective for CML, but in many cases enough to go patients through the pregnancy and after delivery to really restart the TKI. For males, it's a different story. We don't have so many information about that. I personally tell my patients, my male patient who has sexual relation with their partners, that there's always a very small, there is a risk of something can happen, but the truth is not being as well studied. But it seems that there is not much effect on the spermatogenesis, but we don't have other implication of these drugs in the development of the fetal.
Interesting. What do you tell the spouses or children of your patients in terms of support?
Well, I think the family is extremely important in the life of a patient with CML. And one of the things that we really reinforce and emphasize is that the family support is crucial, mainly for adherence, right? I think it's very easy for patients sometimes to forget the pill, and I think to have a spouse, a relative, or someone close by who really track the amount of pills that patient has, I think it will be very, very important, and I would definitely encourage many of the relatives to really follow these conducts.
Now, what if the patient's PCR level of the chromosome translocation begins to increase in their blood? What happens then?
Well, normally once that the patient is being diagnosed, is being controlled with the milestone that we are referring to before, we follow patient every 3 months, and it's a nice way to really check by peripheral blood how the disease goes with a very simple test, the RT-PCR. The RT-PCR can really go in different directions. They can go down, and we have many studies for many years that even in the imatinib patient after 4 or 5 years can continue to drop the transcript of BCR-ABL. Many patients are stable, and some patients will start to really have a raising on the transcript. The first thing that we need to address is adherence. Adherence is the most common case of what this happen. Other cause is variation in the laboratory. Many people use different laboratories and change the labs, and then they have this conflicting data who really make them think that the patient is progressing. And finally, of course, is the fact that patients start to to get resistant to the drug they are taking. Why? Because they may occur specific mutation in the ABL kinase will enable the drug to fit into the area where they block the activity. For which I think is important in some cases, one that we rule out, adherence and all these problems that I mentioned, to really order a kinase domain mutation to make sure that the patient is not really start to experience a relapse based on this fact.
How can you check whether someone's been adherent? Can you check the drug levels, or do you just go by the patient's word?
That's an excellent question. In the past, Gleevec imatinib levels were able to be done through Novartis, the company who manufacture imatinib. Unfortunately, this test is not right now available. There is some commercial labs that they are trying to really implement it, but right now is a matter of have a very, very honest discussion with the patient, and unfortunately we won't be able to measure the level for now.
I see. And then how do you check if you suspect it's the two different labs that are different, what do? You make sure that the next test is sent to the same lab?
Absolutely. I think there has been a lot of problems in the determination of BCR-ABL by RT-PCR in the United States, mainly due to the fact that there is more than 100 different laboratories who have different standards. The European community and the European Leukemia Network has been working very hard to establish what we call international standards who can really be applicable through the world. WHO organization still start to provide a commercial or free kits that can be used in standardizing these techniques. And more we have multiple examples in the US where many labs start to incorporate these international standards to the reports. Why is very important? Because then is the only time that we can compare back to back the results. Of course, if it's not available, what really we recommend to our patients and the doctors who consult us is to really have the test done in the same place all the time.
I see. There's a specific mutation that we all dread called the T315I. Would you please explain what that is?
Sure. As you just mentioned, mutation can happen in ABL kinase domain, and really can really be outside the what we call the pocket where these drugs bind. And some of these mutations, besides this very infamous T359, can really be more sensitive to nilotinib or dasatinib, for which I think it's important to really ask for an opinion, because when patients lose response to imatinib, the opinions of mutation beside T359 can really drive us to use one drug versus another. Unfortunately, T359 is currently the only mutation for which we don't have an available FDA-approved tyrosine kinase inhibitor. And it's a bad mutation to have, because none of the drugs available works. And of course, an allogeneic bone marrow transplant is indicated as soon as possible. Being said that, there is investigational drugs. There is a recent drug who is being developed, and the data has been presented in the phase 2 data has been presented at the ASH 2011. This drug is called ponatinib. It has a great activity in T359, and we hope that this drug will be approved in the next year for these kind of very, very unique cases of CML.
I see. So I guess for right now, if someone needs, what exactly is an allogeneic stem cell transplant?
An allogeneic stem cell transplant, well, is the substitution of the whole hematopoiesis, or the production of the stem cells by other person who is donating this bone marrow, right? It's the substitution of one bone marrow from the donor from the recipient, right? In this case, it's allogenic because it comes from an HLA match or an unmatch. Match means that most of the time they are brother and sisters who has really a full match DNA. In this case, we call the HLA, that is the identity that we're looking for. But of course, we have something called the International Bone Marrow Donor Registry, who really incorporate thousands of patients who really freely donate samples to have HLA identified. And it's very common to have be able to identify an HLA unrelated match. Means it's someone who has very similar identity to us, and for which an allogeneic bone marrow transplant can be performed.
So nowadays, what percentage of your patients actually will get all the way to an allo transplant?
That's a terrific question. Before the era of TKI and even in the interferon that was in the 80s, every young patient who has CML was really sent to have an allogeneic bone marrow transplant, and it was a very common really situation for the bone marrow transplant departments. Since the incorporation of the tyrosine kinase inhibitor, in this case imatinib and nilotinib and dasatinib later on, well, this is very rare to really send patients to transplant, but of course, situation for which this procedure can be indicated are include but not limited to the presence of D359 mutation, as well as resistant to 2 or more TKIs, for which we know that the future of this patient can be jeopardized by the disease, and we don't really, and this is the reason we want to intervene with a more aggressive procedure like such an allogeneic bone marrow transplant.
I see. So in your experience, once someone does develop that mutation, how much time does a patient have before they need a transplant, before the disease really goes into high gear?
It will depend on the phase that the disease is diagnosed. D359 can really occur in chronic, accelerated, or blast phase. And you can imagine in chronic phase, even there's something that needs to be done as soon as possible. The patient has some time. The patient can, even in studies has been performed, you can see that in the next year it's unlikely that this patient is going to progress. But we know by the 2 years the patient starts to really progress in much more frequency. Of course, in accelerated and blast phase, this happens more often, and the allogeneic bone marrow transplant should be performed as soon as possible.
I see. So sometimes patients with CML have a large spleen, like you alluded to. Why is that, and would the spleen get smaller with the treatment?
Absolutely. As we were mentioned before, it's a classical complaint at presentation. It's early satiety, who really is a manifestation of the growth of the spleen and pushing the stomach in a way that patient cannot really have a full meal. This symptom or this sign disappear very, very fast with the incorporation or with after starting medication with tyrosine kinase inhibitors.
I see. So I think more than anything, our patients from us want hope. How do you give your patients hope with CML?
Well, I think right now the hope is there. I think the diagnosis of CML still is a very traumatic one and very stressful. And to say that, it's still a leukemia, but I think the good news that we have an excellent therapies that can control the disease. Right now, what is in the conversation of CML expert as myself is how we're going to find the ultimate cure of this condition. And although we feel that our patient can stay in the drug for the rest of their life, there is still a need to really find how to eradicate the ultimate CML stem cells, and after which we will be able in the future, hopefully with the new research that's been done and is being conducting currently, to be able to stop therapy and to say that we can cure CML for once.
Thank you so much.
Thank you very much.
Thank you for watching. We hope this has been educational for you as well.